99.7 FM with me, Nortey by nature, and I'm joined by my specialist in family medicine at the Kolibu Teaching Hospital, Reverend Dr. Ernest Enimopare. Today we take a look at childhood obesity. We want to understand the risk factors, possible complications, and prevention strategies. Yeah, we like talking about weight issues when it has to do with adults. But these days, in fact, for the past couple of years, decades, there's been a worrisome increase in the number of children who may be diagnosed, classified as overweight or obese. What does this mean? And what are the possible triggers or risk factors that will increase your child's vulnerability of becoming obese or overweight? What are the possible complications? What leads to this? That's why I brought Reverend Dr. Ernest Enimopare into the studio. Doc.
Boss.
Akwaba.
Well, that's it. Good afternoon to
Or should
you.
I now call you specialist? Specialist in family medicine. You know, over the years we've had you several times on the show, and it's been resident
Yes,
or
please.
trainee
Yes.
in family medicine. Now you are qualified specialist.
Yes, boss.
Right? And it wasn't by votes. By examination, right? Examination.
Yes, please.
I am most happy to have you, and of course I'm so happy for you.
Yes, it's always a privilege to be here, and I'm grateful to you for the opportunity.
Right.
Good afternoon to our listeners.
Okay,
as well.
he's my bench, you know. Anytime I'm not around, I reach out for him, and very, very soon, you know, I should be thinking of retirement, right? But Ernest, it's great to have you, and
Great
I
to be
yanked
here.
you in to talk about childhood obesity or overweight children. It's a significant public health concern across the world.
Yes, it is.
In our parts of the world, you put on weight and you've arrived. You're actually doing well.
Yes.
But we have reasons and justifications to be concerned about weight issues when it comes to children. Can you just help my listeners? What's the justification? Is it really a big deal?
It is a big deal. Once again, thank you for the opportunity, and good afternoon to our listeners. It's always an honor to be here. So, it is a big issue. Like you said early on in the introduction, many a time when we look at malnutrition as a spectrum of disorders that have to do with children who are either overnourished or malnourished, especially in our part of the world, many would think that we have many more people who are undernourished. But it is a fact that over the past couple of years, there is an ascendancy in terms of the number of children who are either overweight or obese. Much later in the discussion, I'm sure we'll touch on the complications. But the reasons why this is a bother is because we all know that with the technological advancement and many other advancements, especially in the economy and other things, people will not necessarily have as much space as they would have had when they were much younger. I remember when I was younger, as I walked to school, maybe from North Kanishi to Kanishi Presby, where I used to school. I mean, there are several school parks that you can stop along the way. So if you left school at 2, you may be playing like 4 football matches before you get home.
That's a Kobolo confession, right? But he's now turning it into health promotive advice.
Yes, you know, some kind of justification. But the issue is that now it's not that common because more of these areas are turning into places either for industry, or there are several developments that are going on that tends to deprive younger children.
So urbanization
is the main thing. Urbanization
has
is
crowded out the spaces for exercise
Exactly
that was health promotive.
Previously, yes,
Right, and the same urbanization and development has led to a transition in our diets as well.
Precisely. Precisely. So if you are looking at the risk factors of obesity or being overweight in the childhood bracket, then these two come into play. They are the major factors or forces that come into play. Urbanization on one side, that comes with the deprivation of the spaces to play, the time to play, and of course the transition in our diet to more refined carbohydrates and everything comes to play. And it's a big issue because one would think that across the globe, many of us would think many people have more nutrition in Africa because of more undernourishment. That's to say that they are underweight. But we have 25% of the global prevalence of obesity in Africa. So it is an emerging trend that must be taken notice of.
Okay.
I want to also add that there was one study that was done between 2001 and 2019 that pulled a lot of studies together.
That's
through
ECOWA.
a meta-analysis. And it was instructive to know that in Ghana, as we speak, the number of children who are either obese or overweight, if you pick 10 children, 1 out of them will be either obese or overweight, and it's instructive.
Right.
So it's quite eye-opening that
quite a serious problem.
Yes, we don't look over this, and it's something that we should deal with.
Folks, if you just joined us, it's 15 minutes past the hour of 2 on Joy 99.7 FM. My name is Nortey by nature. I'm in the studio with Reverend Dr. Ernest Enimo-Parry, specialist in family medicine with the Kolebu Polyclinic and the Kolebu Teaching Hospital. We're looking at the alarming trend of childhood obesity and childhood, should I say, cases of being overweight, right? We'll look at the diagnostic criteria, what determines who is overweight and who is obese. Of course, obesity being the more severe condition, right? We know of the body mass index and other indicators, percentiles, and other things that are used to classify and diagnose these children. We also know that it unfolds into a range of possible or potential complications, be they physical, psychological, and social. And we need to be aware of these things, and we'll move into preventive strategies as well. Is your child overweight? Share with us, right? And hey, how much of this is inherited? I mean, come on, my dad was big boned and big body. You know, this is how we are. And somebody has to be big, somebody has to be, chingilingi, right? But when it comes to public health concerns, this is a serious issue. 8.6% and 10.7% of Ghanaian children, by a recent study published, I think, 2020, are either obese, that's the 8.6, or overweight, 10.7. That's serious stuff. Serious numbers. And indeed, again, when it comes to know your numbers, your blood sugar and other things, we tend to overemphasize adults.
Yes.
So it's good we're talking about these things.
Let me just chip in this for somebody who thinks, okay, it's just an emerging trend. Unfortunately for Ghana, when it comes to the developing countries, the average they put in our part of the world is about 6.1.
Right.
So if you're even going to compare Ghana to countries like other African countries who
we are above that average.
We are still above that average.
Okay.
So it is an emerging trend that needs the attention that we are trying to bring on board this afternoon.
Okay. And let's come back to some of the, I prefer risk factors to causes, otherwise people start arguing, right? But what are these predisposing risk factors? We've talked about the dietary transition.
Yes.
We are eating more of these sugars and other things that were not typically or traditionally part of our diet. Let's talk a bit about that. What kind of things are we stuffing the kids with, or are they stuffing themselves with?
Yes, so before, just for listeners who tune in, I just want to make this emphasis that unlike adults where we use categorical as it were, numbers to define what obesity and overweight is. So for an adult, a BMI, which is your body mass index, if it happens to be more than 25 but less than 30, we say you are overweight.
Right.
But for somebody who is obese in an adult, we say your BMI or body mass index is more than 30. On the other hand, when it comes to children, the ratio between your weight and your height does not accurately determine the fat distribution in yourself. So in children,
that's one of the critiques of the BMI.
Exactly. So in children, it is further scaled down to what we call the centiles or the standard deviations.
Right.
So, I mean, if an adult is listening to it, they can just go and check their weight, check their height, compute it, and then they are done. But for this discussion, if you're a parent, you're a guardian, you are a teacher, whoever you are, if you want to know the BMI of your child, you may have to download what we call the age-specific charts.
Right.
And then there's a WHO
we have growth charts.
Growth charts where you look at the age of your child and the gender. Right. So you cannot just use, my child's weight is 20. Of course, sometimes you can see somebody and see the person is plumpy.
Right.
But to be more objective, because much later when we talk about
compare them to other children their age.
You have to compare people of their age.
Right.
And if you are looking at treatment, you may have to know your starting point.
Right.
So the take-home message is that when it comes to children below 5 years, when we say somebody is overweight, it means that their, the standard deviation is more than 2.
Right.
And if the person is more than 3 standard deviation, if you use the chart,
Right.
then we say the person is obese.
Okay.
On the other hand, people prefer to use the centiles.
Right.
So centiles is like saying you have 1 to 100.
Right.
If your child is on the high end, which
Right.
is the weight is
Higher.
higher,
Higher than-
95%
right.
of the class. So usually the centiles just means that we are comparing your child to 100 other children. So if you pick your child's weight and your height and the height of the child, and it is above the 95th centile, it means that for a group of 100 children of the same age, the same sex, your child is only amongst just 4 people
Right.
who have the same BMI.
Your child is heavier
Is heavier
than 95 of
exactly.
them. Right.
So 95 of them are below.
Below.
So that is a cause for
Right.
worry.
Okay.
And if it's 85%, it means that your child is heavier than about 85% of these children.
then
Which
that
means
child
that
is overweight.
exactly. So
Okay.
that's to put in simple terms. But
Right.
unfortunately, I may sometimes our listeners will say, "Oh, my child's weight is 30 kg. Can you tell me whether it's overweight?" I
Right.
can't do that here because I need to know the child's weight, know the child's gender, and then we plot on the growth chart.
Okay.
So now talking about the risk
Just
factors.
a second. Just a second. Slow down.
Okay.
Slow down. You see the specialist in him, right? If you just joined us, it's 21 minutes past the hour of 2 on Ultimate Health. We're taking a stab at childhood obesity, right? And want to understand the risk factors, okay? And we were just explaining some of the diagnostic cutoffs,
Yes.
right? If my child heavier than a certain percentage of his age peers, and the important thing that we're pointing out here is that there are growth charts which allow you to compare your child's growth and weight to children their age, okay? And this kind of baseline or normative data is very critical and central, right? So we don't just get up and look at the person and their cheeks and their stomach or the size of their school shorts or blouse and say they are obese or overweight, right? The BMI will give you your height to weight ratio, but it does not necessarily speak to bone mass or the distribution of fat or weight across the body. So that's what Ernest was trying to explain. We're now going to look at the risk factors. Why is it the case that our children, more than before, are falling into this category and meeting the criteria for this diagnosis? Emphasis on diagnosis. So we are dealing with a condition.
Yes.
Right, so this is important. If you want to share your experiences with us or questions, 055 11 11 997. Those are the healthy buttons to push to get through to our WhatsApp box, and we're live on Facebook and YouTube as well. My guest is Dr. Ernest Enim Opari, Reverend Dr. Enim Opari. Yeah, he wears many hats and collars, right? And the stethoscope. Right, so this one says, good afternoon. Hang on a sec. Let me see if I can just click on that. Okay, I've got the wrong mouse. I'll get back to that. But let's come back to risk factors.
Yes,
so
so
the dietary transition is one.
Yes.
Are they eating too much? Or they are eating the right amount of the wrong stuff? What do we mean when we say there's been a change?
So the transition encompasses a lot of. I must say that when it comes to childhood obesity and being overweight, it's not just one factor at play.
Right.
In a particular child, a lot of factors come to play. So one, they can be taking a lot more than they should.
Right.
Two,
So that is quantity.
the quantity.
Right.
Two, they may be taking perhaps a good quantity, but a lot more times than they should be taking.
Okay, frequency.
So, frequency. Three, they may be taking what they shouldn't be taking. So you say, oh, as for me, I give this maybe this, or I give just that. I give burger. I give. That's not to say it's bad, but if you give something that is not supposed to be given too many times, then you stand at risk.
Right.
On the flip side, then you have a child who, having taken all of this, which contains a lot of calories, is not able to expend the calories that come with the foods that they are taking. So the same food, if taken by another child in another home, who maybe expends a lot more energy playing games, I mean physical, not video games
Right.
or virtual games, but playing more games, doing a lot more house chores that require expending energy.
Okay.
They will, for the same age group, the same gender, a child who eats the same food but is involved in a lot more.
They are
physical
burning the
activity,
calories.
They are burning their calories.
So you need to know the caloric content of the
Exactly,
food,
of the food.
and then relate it to whether that child is exercising or exerting themselves such
Precisely.
that they can burn it off. Because when you
Precisely.
don't burn it off, you lay it down.
That's the summary. I
Right.
like the way you put it.
It's like your bank account.
Exactly.
Right? If you deposit and you don't withdraw, then your balance goes up.
Yes.
Right?
So
So these
actually-
children are
yeah.
eating,
Yes.
and they may be eating high calorie content food
Yes.
frequently
Yes.
in high quantity
Yes.
and doing next to little or no exercise.
So the balance shifts in the favor of conserving energy or the
Right,
calories, which
right.
leads to a lot of weight.
So your body lays this down.
Yes.
Okay.
Yes.
This is simple, right? Right? So if you're big, one of the factors or one of the mechanisms is what we're talking about, right? You're eating a lot of stuff. Invariably, that stuff is high calorie or high energy food of the wrong types. And because you're not physically active, you are not burning the energy, right? And therefore, it is laid down by your body. And therefore, your body mass increases, okay? And we know when we look at the schools, they are all nice and air-conditioned and sliding windows, and we're so happy just looking at the aesthetics of our children's schools. Do they exercise? Do they go out? And so on and so forth. Even at home, everything is tied up and packed close. You have more space for the water tank than for your children to run around. And these are all factors that relate to diet and also physical activity. That's what you're saying.
Yes. And let me also add that research has shown that there's a genetic component, but it has the research shows that about 25 to 40% of children who are either overweight or obese tend to have parents or a certain genetic predisposition.
All right.
But it is not as though once your
It's not
father,
automatic.
Yes, it is not going to be passed on. So there's still an environmental interplay.
Right.
Unlike certain genetic conditions where, for instance, once your mom or your father has it, is passed on to you.
Nature and nurture.
So nature and nature plays a role. It is so sometimes, like you said in the introduction, somebody's, as for me, I have a big father, I have a big mother. That is true.
So, papa.
But it doesn't mean that your father's genetic took preeminence, that even if you were eating well and exercising as you should, you will still grow that big. So that's the distinction.
Great stuff. Let's understand that. Okay, it's not automatic. It's a predisposition, as to whether it will come to pass that you'll be big or you'll have weight issues is another thing. Oye Nafienya, thanks for welcoming me to your home. I've got this from Doctor. Please, what causes obesity in children? That's what we're talking about. Okay. I believe that's the only question you asked. Okay. We're looking at the risk factors. Okay. It's not one-on-one, so we don't want to tie it down to cause, right? But some of them may have causal effects or impact. I wish to know the reason for the introduction of the undertaking in the entrance exam, especially when it has been reinforced through, this is for the other program, the legal program. Nortey, some health sources attribute drinking water immediately before and after meals as a contributory factor to improper digestion, which leads to a lot of ill health. How true is that? And also, it leads to obesity. That last point or part of your submission, I don't know whether it's a question or a conclusion, right? You are asserting that it leads to obesity. Jonas from Lashibi.
It doesn't, if this particular question in terms of drinking a lot of water before and during or immediately after does not necessarily lead to obesity, but it is poor nutrition, because many a time, unless of course it's very important, as you drink more water and you eat, you are less likely to finish up what is before you. So it doesn't directly lead to obesity. There's no study that leads to it. But more likely, if the child is drinking more water as they eat, they may rather be undernourished. But it doesn't mean it's better than obesity, because there's always that mindset.
All right. Yes. Okay. Thank you, Jonas in Lashibi. If you want to send one, it's 055 11 997. This is Ultimate Health on Joy 99.7 FM. We're looking at childhood obesity, right? Children who are overweight or obese, right? To the point that it causes or it has health implications. That's what we're looking at it, right? That's why we're looking at it on Ultimate Health today with Reverend Dr. Ernest Enimo Parry. So we talked about exercise, we talked about diet, right? Is there anything else that is contributing or driving or fueling
other
this?
Studies, like we say, these are risk factors. It doesn't mean that it will lead to it. Risk factors like birth weight. So birth weight usually greater than 4 kilograms.
So you were a big baby already.
You were a big baby before you actually started what do I say, engage in any kind of physical
It's a wow,
activity.
they are sent by.
Yes.
Right.
And then people of higher socioeconomic status tend to have children who usually would be either overweight or obesity. Remember, these factors are just associations or characteristics or exposures that can increase the chance of a child being either obese or overweight. It doesn't mean that if you were born 4 kilograms or more, or you come from a home that is of a higher social economic status, or if you have parents who perhaps have higher whether there's parental obesity or all of this can come into play in a particular individual, and the person may still not be overweight or obese. So these are risk factors. They increase the chances of you being either overweight or obese.
Okay. And I'd like us to go back to diet because, of course, everything begins in the home. Could that be a factor that the food preferences of the home, of your parents, what is on your menu at home? I know there are homes where sugar does not exist, right? And they get on fine without sugar. Right, there are homes where the in quote sodas or the fizzy drinks are taboo, and you will not see them unless maybe you go and live in another family or another house. Does this also contribute to the dietary preferences and possibility of developing these issues?
Yes, you couldn't have described it any better. So this is very important, and in fact, even though genetics plays a role, other studies have pointed to the fact that many a time children become socialized from their houses or their homes, such that if a parent is either overweight or obese, it doesn't necessarily translate into genetics. Rather, it is as a result of what the child sees being done or eaten.
So lifestyle behavior.
The lifestyle behavior continues from the home, and you will see that there is a particular trend in a particular family. It doesn't really mean that perhaps the aunt passed it on, but maybe they are used to taking particular drinks.
You're modeling what you've seen.
Yes. So you don't take your lunch without a drink, and it becomes that's what the child grows up to see. So you're right.
So eat your food for me might mean that there's Coke on the table.
Exactly.
Or fruit carton juice.
Something to add.
Stuff like that.
Otherwise, I've not eaten.
All right. Otherwise, it's not happening. In fact, it becomes manipulation and sometimes some kind of bribery.
Yes.
Right?
Yes.
And there are many parents who also reward their children with food.
Yeah.
And food products. You've been a good boy, get. And it is food.
You're right. I'm laughing because there should be a balance.
All
I mean, there are times when you can reward your child, and I think it's practical.
Right.
That, okay, this is your favorite food. Do this for me, I'll give you. But that favorite food that contains a lot of calories cannot become the menu of the house or the home. It's not sustainable in terms of the long run.
Pasolo Sunyani is still asking this question whether it is congenital or inherited or based on lifestyle or environmental factors.
So when it comes to obesity and being overweight, science says that it is an interplay of these two. One, genetics plays about 25 to 40% of the chances that somebody can be overweight. But even in people who have a genetic predisposition or chance of having or exhibiting obesity overweight, if they are situated in an environmental framework or place where they can expend the energies or the calories that they've taken in, they are at a better chance or a higher chance of not developing obesity or being overweight. So it is an interplay. We shouldn't look at it one dimensional because it is easy for anyone. Yes, it's not binary. It is not either this or that. A lot of things come into play.
It's not black or white. Okay.
Yes.
Right. Send your questions, concerns 055 11 11 997 Ultimate Health on Joy 99.7 FM with me, Nortey Dua. It's important to understate or emphasize, underscore the importance of this discussion. We have children who are running around. Today they are fine, but they have a vulnerability to certain other physical, psychological disorders that we'll be talking about, right? So it's important to talk about this and take a good look at your child. Don't diagnose. And I will be asking Ernest who you should be seeing, a pediatrician, a family medicine specialist, or who should you be seeing? And at what point should you be concerned? Okay, we changed his shorts last term. Now we've gone 2 sizes up, and even that one, all right? We'll come to that. But Ernest, sometimes there are psychological factors at play. And these may tip somebody into the regions we call obese or overweight. What would you say to that?
So let me answer in the reverse. So it's more like a vicious cycle.
Right.
Sometimes, and
chicken and egg.
yes,
Okay.
you may have somebody who, I don't want to say it through no fault of theirs, they are obese at the point where you make a diagnosis.
Right.
And people keep teasing them. Their mates in class keep teasing them. Teachers keep throwing jokes at them. And so what they need to do, which essentially has to do with engaging in more physical activity,
right,
they are not able to do it because they look big on the outside, and they are scared that if they do engage in any kind of activity that their mates are involved in, they'll be teased. Hey, she's too big and she's playing football.
So in this instance, the obesity or the being overweight leads to the psychological issues.
Yes. So instead of us breaking the cycle where, okay, you're obese, because on the contrary, somebody who is obese or overweight actually needs to expend more energy in physical activity. But because of the depression that they may have, the anxiety that they have, if I go and play football and I fall, my mates will laugh at me, my friends in the area. So they are indoors because when they go out, they have low self-confidence. People are not easily, what do I say? They are not sensitive.
Right.
Especially in the way we describe people. Sometimes when they say obese, overweight is okay, but in our local languages, or your bolo, so so the description, they don't allow these children to even come out of their homes to join them in the first place.
Right.
The other thing is when children sometimes are put in a situation where they have a lot of choices, like the psychological thing. So they want to look like somebody. They not really put on weight, but they feel like they are smaller. Sometimes my child says, "Oh, this our classmate is bigger than me. I want to be as big as." So they don't tend to become as big as. So
those anxieties, insecurities
so
can lead to
problematic
patterns.
Yes, that's another thing.
Okay.
So those are the two things that based on.
What about children undergoing some form of trauma and stress? There's some body of research that shows that in response to these events and phenomena, they tend to eat as a kind of a defense mechanism that also has some comforting potential.
When they suffer either maybe some social stresses, they may not be doing too well in school, and so instead of maybe going for, like you said, it's actually very practical. Just talking, I just remember. So maybe instead of going for the usual lunch when maybe your friends are, they rather take maybe 5 or so bars of chocolate.
Right.
And to them, it's actually nothing but that is very high calorie content.
Okay.
So maybe they are not doing well in school. They are shying away from other people. They don't have the self-confidence to move out. Not because they are big, but gradually it's eating them up, and they tend to eat a bit more to cope for it.
Okay.
And they are not relating with their colleagues, so they are sleeping most of the time at home and everything like that.
Plus, I'll chip this in that, when you're under pressure, under stress, your body craves the wrong foods. That's when you crave the sugars and all the complex things that will cause the trouble, and raise your cholesterol and all that. It's well documented. 38 minutes past the hour of 2 on Joy 99.7 FM. This is getting interesting. So we have kids who, in quotes, through no fault of theirs, become obese or overweight. Let's say we've done a good job or a partially good job in explaining the factors, in explaining how we diagnose these things. There may be some genetic or hormonal issues that are in there. Right. At what point do you see a doctor?
Okay, thank you.
At what point does it become a health issue for you, the parent, for you, a school teacher watching your cohort go through the school and like, hey, Junior, at what point do you raise the concern, and at what point is it justified to now proceed to seek a medical or clinical opinion?
Ideally, for preventive measures, we would rather parents, for newborns, there's this systematic follow-up after they are delivered. So maybe you go to the clinic after 1 week.
You go for weighing, they check if they are thriving and all that.
But most often than not, it seems to end after 5 years.
Right.
I know some people continue, especially when they have special needs, either because of pregnancy complications or delivery complications. But as a parent or as a guardian or as a teacher, you may want to take the responsibility of perhaps following up once in a year. Not necessarily
have your child checked up.
Have your child checked up.
Comprehensively. Not just because of weight.
Exactly, because that is one of the earliest way that you can pick it up. But I concede that it's not something that we usually do.
Right.
And also, like I said early on, to be able to estimate or make a diagnosis of BMI in children,
Right.
you need to plot along the growth chart.
Right.
So it may be a bit difficult.
And you have that growth chart in your booklet when you
Yes.
go for weighing.
Yes.
Right. There's
Yes.
a booklet that gives
Yes.
you baseline data
Yes.
on your child's
Yes.
growth.
Yes.
And it's very, should I say, key, pertinent information
Yes.
about your child and
Yes.
their development.
Yes.
All right.
Yes.
And what Ernest is saying is that why break that pattern after 5 or when you feel the book is full up,
Exactly.
right?
Exactly.
When you all come with your white whatever cloth and it's all la-di-da,
Yes.
right? And you're quite compliant.
Yes.
But after that, your child, nothing happened to them. They didn't get cholera. They didn't get this. They've had their vaccinations and so on and so forth, immunization, and they're in school. What again?
Yes.
Right? You're
And-
suggesting that stay on track.
Yes, there should be continuity because I
Right.
like the point you raised. When these days, for the expectant mothers, for instance, they have one book that continues the whole pregnancy.
Yeah, I've forgotten the name
subsequent
now.
pregnancy.
The book.
Yes. So, in the same vein, for a child, you are not even waiting for them to go above the 85th or 95th centile, because weight doesn't just accumulate.
Okay.
So, for instance, if my child was around, usually want them to be in the above the 50th and maybe the 70, between the 50th and the 75th, but no more than the 85th.
Right.
If my child used to be maybe 60th percentile,
Right.
and then I see that grade is going to 20, 65, 75, my child is still neither overweight nor obese.
Right.
But those are danger signs.
But I can see the climb.
Exactly.
Okay.
So,
So
those are
like
the
we did for
things.
COVID, flatten the curve.
Yes.
Right?
That's a nice way
You
to
are
put it.
plotting a graph and you're seeing that this is the rate of growth
Yes.
in terms of weight of my child.
Exactly.
And that should be of concern.
Exactly.
That's what
So
you're saying.
That is the
Right.
primary way of finding out. But assuming someone is listening to us and maybe has missed, because most people will,
Right.
has missed this period of following up yearly.
Okay.
Then you can tell. Your child comes to you and says, my dresses or my shorts are not fitting any
Right.
longer. Your teacher says, my child is not fitting into the chair or something. Complaints come. Your child says, people are teasing me
Right.
that I'm bigger than
Look
I
out for these things.
Yes. So those are the things that you would have to come. You don't have to take it lightly. You know, sometimes as parents, we want to take responsibility on our hands.
Right.
Okay, I'll stop giving this and that, especially when the person who reports becomes a bit confrontational.
Right.
Maybe your teacher or your Sunday school teacher says, hey, what's happening? You are giving so much food. They say, okay, I'll stop giving you this or that.
Right.
You need a comprehensive approach.
Right.
Because you cannot intervene if you don't know where we are starting from.
Okay.
That's why in the beginning I made mention of the references. So you need to know the exact weight, exact height, where we are starting from,
Okay.
and adopt a comprehensive approach.
Right.
It's not just depriving the child the food,
Okay.
because whatever food that they are taking, it still contains some calories. So it may be on the side of balancing with physical
Okay.
activity.
Right.
Like you said, they may be deprived of a
Lifestyle
lot of physical
changes.
activity.
Right.
And you have to do that.
Okay.
So in addition to screening, if you're asking me how to make this diagnosis, in addition to screening regularly, maybe annually, if not even biennial,
Okay.
you should look out for your child. Are the dresses fitting? Are they complaining that they can't sleep? And some of the things that you would realize, it comes under complications of being
Right.
overweight or obese. But let me just chip it in.
Okay.
Children who are overweight or obese tend to have a higher risk of having what is called the obstructive sleep
apnea. Okay.
So they snore loudly when they sleep, and also they have excessive. All of us
Because
sometimes
the airway is blocked. Right.
and just like you see them big, the tonsils
tongue,
and the adenoids are also
right.
becoming big.
Right.
And research shows that the tone, that is the ability to either contract or relax
Yeah.
or hold it together, the airway hold it together, it becomes more lax. So then they find it more difficult to maintain.
Especially
an
during sleep, where they
Exactly.
are
So,
semi-conscious.
all of a
right.
sudden, your child who didn't used to have these tend to have it. That's not to say the diagnosis is being obesity, but they can raise the red flags.
Okay.
The clothes are not fitting. These other symptoms are coming.
Okay.
out. Yes.
Right, definitely good stuff. Good afternoon, big man. Is that me? Please, I want to ask a question. What kind of food can we eat to prevent obesity? It's not a matter of, should I say, avoiding certain foods. It's about knowing about the foods and the combinations, and then looking at the quantities and other things, and then integrating that with consistent lifestyle changes that will bring about, what you're looking for. But we'll get to that hopefully in a bit. All right. 44 minutes already. Wow. Past the hour of 2 on Joy 99.7 FM. My phone line is active 0302 216 0302 216 Right? Questions, concerns, experiences, confessions, testimonies. Right? Most welcome on Ultimate Health. Joy 99.7 FM. We're talking about childhood obesity, understanding the risk factors. You see, we seek to inform and then ultimately transform. So that's why we want you to understand. We don't want the resource person to be the only one who has the information. He's sharing and building bridges, all right, rather than walls, okay? And then we'll look at the complications shortly. So if you have anything to share, 0302 216 those are the healthy buttons to push to get in on the action on Ultimate Health. We're live on Facebook and YouTube.
99.7 FM.
All right, so we have some understanding that there could be a problem with a particular child. My reading surprised me. The meta-analysis of the Ghanaian data revealed or unearthed that there's a higher probability when it comes to girls or females. Okay, it was not found to be significant, but in nominal terms or nominal values, the girls had a higher propensity to develop this. There wasn't much emphasis put on that, right? But we're discussing it generally, okay? Generally, right? That this is a problem, a public health concern we need to look at. So, what's the big deal? Okay, my child is big. He's getting his grades. He does everything else all right. He has friends. What's the big issue? If it's not broken, don't fix it. So, what's further downstream? What could happen to a child who fits the criteria we've just talked about, is in the percentiles we're talking about, the BMI is also around there, and then other clinical history meets the match? What could potentially happen to such a child?
Yeah, if anybody listening thought, okay, if it's not broken, don't fix it, then in some ways it may be broken without you noticing.
Ernest, let me just stop you and take a caller on the line. Hello, good afternoon.
Hello, boss. I hope you're doing well.
Right, a jingo in Tema.
As usual.
I've never met you, but you sound obolo.
No. When you see me, you see that now exercise is very strong in me.
Okay, right. Share your question quickly.
Not entirely a question, but a submission.
Okay.
Your guest is on point. I mean, it's a very good topic, and I think we need to add some certain stuff into our food, like garlic, ginger, other vegetables. That will help digestion. Because you can decide to eat good, but if the digestion doesn't take place nicely, it's also, getting into your body, and obesity can set in. So I think your guess is on point.
Okay. Right. The Ajingo factor, garlic and other things, to promote good digestion, right? Otherwise you waste the food. There's another call on the line. Hello.
Yeah. Good afternoon.
Good afternoon. Who am I talking to?
My name is Henrietta.
Henrietta. Wow, my mother's name.
I know. You've been saying it always.
You see, you're welcome. Share with us, my dear.
My grandchild, it's my sister's grandchild, but it's my grandchild as well. He's obese, and you know what? I know the father was like that. The father is huge.
Right.
And he has taken, not the father, but grandfather. And the father too has been like that, but the father monitors his food. He knows how to eat. He's a dietitian, so he knows what to eat and what to. But this boy, 13 years, he will drink Coke, 2 bottles. He will eat biscuits, full pack. He is nyama. Now he's diabetic.
Oh goodness.
13 years, and he has asthma too.
Wow.
Yes. When you tell him not to be eating, he will be hiding. When he goes to school, there is worse. So we I don't know what we can do for him. So please advise us.
Right. Is he seeing anybody? Is he under management?
He is. But I don't think it's good.
Okay.
I don't think the man works. When you talk to him, he should eat a lot of leaves, He doesn't like it. He likes frying eggs, Indomie.
Right. Thanks for sharing, Henrietta. Do we have another caller? Nope. Okay. So this is a good case
Yes.
point.
So this is actually a very good
There's
case.
something which looks familial or genetic,
Yes.
right? It could be
Yes.
the behavioral part of the eating habits that he picked up from his dad, but
Yes.
definitely there's some transmission there.
Yes.
And now she's mentioning the complications we're going to talk about. Sadly,
Yes.
asthma, right?
Yes.
And
Diabetes.
diabetes. And he's
there are other-
13.
Yes. At
He is
13, yes.
13.
So that's something that our listeners must take note of. Many would think diabetes, hypertension are conditions
Right.
of
And essentially here we're probably talking about type 2.
yes,
Wow.
most likely
Most likely.
type 2. And so diabetes is not a preserve of the rich or the old people in society. It is an imbalance of calories and your body inability to deal with it.
Okay.
So if you have an individual, whether child, baby, whatever age, and there's so much calories being taken without it being expended,
Right.
then there's a higher chance of having it. And
Okay.
so this is one of the, sometimes when we talk about this, somebody would say it's not real, but I'm happy that we have a case in point that
13-year-old diabetic.
13-year-old who has a diagnosis
Also
of
asthmatic.
diabetes and also asthmatic.
Right.
Like we said, with the asthma, there's also the airway problems with obstructive sleep apnea,
Sleep
because when
apnea.
they are sleeping, they'll be turning and then they can't breathe. The cardiovascular risk, other ones include hypertension.
Right.
And then
even in children.
yes,
Yeah.
in children. The other one, either they develop it in childhood or they have a higher risk of developing it as
later.
they go. Yes. And the other thing that many of us may turn a blind eye on is the fact that they have specific psychological issues.
Right.
Because they are obese, like this particular boy in question. They may not voice it out and they may actually be eating.
Right.
Like we said in the introduction, it may look like a negative
It's a defense mechanism.
it's a defense mechanism. They know that they don't have to eat, but they just cannot
So
stop
there are
because
impulse
they've given up,
control issues.
and so they keep
There
eating.
are psychological issues. It could be body image issues and many
Exactly.
other things. Being
Exactly.
taunted,
So-
not being able to do things.
It goes on, and then there's musculoskeletal issues.
Right.
The risk of having osteoarthritis is higher in people who are either obese or overweight.
Wow.
And children are no exemption at all.
Right.
So usually when we hear about osteoarthritis, many of us will think about the elderly because of the degenerative changes. But if a child continues to put on weight and with all of these changes that are going on,
Okay.
mechanical changes, then they are also at a risk of developing
All right.
osteoarthritis.
I have a caller on the line. Hello, good afternoon.
Hello, afternoon, Oti.
Hi, Oti.
Oti Forty from Tema.
Right, share with us quickly.
What I think what I'm talking is really serious. I've seen some guys, small guys, like 12 years, but they're obese. Last time they are walking, they're just in front of my shop. The guy told me that he can't walk. I said, it is hard. I said, you small boy like you, why you say you're hard? But today I realized that the small guy might have some disease. But what can we do? I know his mother very well. What should we do?
Okay.
What advice should we give to his mother?
Right.
But I see his mother too is getting obese like type. But the boy is too much. Biscuit and a toffee and a stuff there. You see the guy always eating it. Walking, eating biscuit, every day eating.
Okay. Right. What can we do? We're hoping we can tiptoe. We only have about 8 minutes left. But Ernest, I'm sometimes able to bully him, especially when I tease him about Tottenham or other things. Right. But we'll break down, should I say, the roadmap, right, that we should be looking at. These are serious issues that you do not want to be contending with when your child is in their developmental stages, their formative stages, where you're now dealing with asthma, you're dealing with sometimes even some of the allergies come in there, you're dealing with diabetes, cardiovascular issues like hypertension, sometimes even heart issues for children. Ernest, this sounds scary, right? And it's not a recent development.
No.
And it's been a cumulative build-up. Indeed, when you look at the global figures, they're expecting this to escalate and worsen.
Yes.
All right? So is it that you, the physicians, are not telling us enough about this or scaring us enough?
I agree that.
Is it a silent epidemic?
I think so. Because it is a trend that has not, as it were, changed since the values I saw from 1990. In 1990, the prevalence rate was put at 4.1.
Right.
In 2010, it was put at 6.7. in 2020 it was put at 9.1. So this
climbing.
is a trend that is not getting better. And I admit that perhaps the physicians like myself are not putting enough.
You like seeing the old folk.
So we need more on this, because you see it's an emerging trend.
Right.
The longer we keep in bringing this to the fore,
Right.
these children will grow.
Right.
And they only
And by
tend
that
to,
time, the habits would have set.
yes,
The
and
preferences
they
would have
may
set.
add on, I hope not, but
Right.
they may add on to our already big group of children or
Right.
patients with chronic conditions,
Okay.
which is a worry. And just to answer one of the questions that came,
Mm-hmm.
how do we go about it? So like you said, two arms of solution, because we can't do much about the genetics. The physical activity arm
Right.
and then the intake arm. When it comes to physical activity, the World Health Organization, the last guidelines on physical activity shows that in children, they should have at least 60 minutes of moderate to vigorous physical activity in a day.
Right.
Many of us know about the one for adults, which says...
Right, Tobo. Take your time. Rewind, reverse.
Okay.
60 minutes is an hour.
Yes.
I'm looking at the typical school timetable, even for kindergarten. Right? An hour. Right? Cumulative.
Yes, cumulative. Yes, of course.
Right.
Not
And I hope the teachers are listening, because maybe next week we'll bring in a few teachers and a
That would be
parent or
excellent,
two to
because
look
we
at
need-
this. Yeah.
yeah,
All right. So 60 minutes.
60 minutes. But a good thing also in that document that the World Health Organization released in 2020 is that, one, it should not be at a goal, and two, there are different domains that you can clock
Right.
it from. So they put different domains, like one, household chores. Like we said, parents and guardians have a responsibility. So you can tell your
Charlie,
child,
the kids of today do nothing.
yes, pick the plate, send it to the kitchen, come back. You can send them whilst they are with you. And that accounts for some part of the physical activity.
Right.
Because when they talk about moderate to vigorous physical activity, includes walking, running,
They don't wash.
swimming,
You
and-
can't send them.
Yes.
You can't do this. And they're stuck behind gadgets.
Yes. So that is one. The
So
the household
increasing
chores.
the level of physical activity is a key pillar
It's a key pillar.
in dealing with this.
Key pillar.
Right.
Key pillar. And remember, these are just minimum. The 60 minutes is not as though you can't go more, but this
Okay.
is the minimum. The other scope of or the domain of physical activity is leisure, where instead of watching a cartoon, you can just decide to go for a walk with a child, because this child is not going to do it on their own.
Get a vegetable garden.
Yes.
Right? We go
Yes.
into the garden, go
Yes.
tend to your carrots or
Yes.
your onions
Yes.
and this and
Yes.
that.
Yes.
And what? They'll
Yes.
say it's slavery?
And the other one is transportation.
Right.
So if you live in an area where you could get something, maybe something out of the home, 5 minutes drive, maybe that means about 15 minutes walk. Go with a child.
Walk with your child.
So if you look at the 1 hour, somebody listening may say, oh, it's not possible, because I send my child, especially the economic situation.
The truth is that adults themselves are not good models
Yeah,
to
so
follow.
It's difficult.
Right.
Because maybe perhaps you send your child to school around 6 a.m., you drop the child off in school, the break time is maybe 1 hour. They cannot be playing all the 1 hour.
Right.
You pick them up around 5, you are in traffic for about 2 hours, you get home around 7. So
Okay.
these are the issues, but you also have to see that there are areas where you can pull these minutes together and still get your average of 60 minutes in
All
a
right.
day. So
Okay.
that's the physical activity
Okay,
aspect.
let me let's read these, and we'll get to tie in a lot of the preventive measures probably next week. So where do we draw the line? I fully condemn verbal abuse and cruel, insensitive teasing, but at the same time, I know several people who decided to lose weight because of the teasing they faced during childhood. So are there instances you can tease or something to help them take practical steps to lose the weight? This is from in Kaneshi, formerly now of Spintex. I've moved to Kaneshi now, and I choose this as my new alias. I am Na, and I'm also Ya, so Yana. So, oh my goodness! All right, but she's making a point there. We are different as individuals. Let me just, so that I quickly do that. Somebody is sensitive, somebody else is not. All right, somebody has willy skin, and indeed, no nickname will stick. Another person is dying psychologically, all the anxiety and all the things. We need to be sensitive, right? As a rule of thumb, it's best to avoid
I think
negative shaming and, those kinds of things, and then draw attention to positive things people can do and encourage them as they make the gains, right? That's important. Yana, thanks for sharing that. I'm trying to wrap up quickly and bully and psychologically twist Ernest to agree to come next week. So that we'll look at some of these. I can see Dede in Maryland typing aggressively. Can you believe my new nephew as a baby was put on a diet many years ago? He was a big baby from the get-go. So you see, you have specialists, you have doctors, you have pediatricians who are vigilant from the start, right, and can actually advise parents. Okay, we ran out of time, Ernest, but it's been great. We'll get to look at some of the preventive methods because we started talking about exercise, increasing, enhancing, I almost said sexual activity, physical activity, right, especially on the part of these children. But we need to look at their calorie intake, right, dietary restrictions and other things that we can put in there, or discipline, let me call it that, right, so that they are not taking in so much energy they are not using, right, and then they are burning what they are taking in. And then there are a few other things that you'll be amazed are helpful. But we've run out of time. So many thanks, specialist, Reverend Dr. Ernest Enimopare, family medicine specialist.
Thank you for having
remind me next week to ask you how many people do have one GP over several years, enough to build a growth chart with a doctor who knows your family growth chart and so on and so forth. In other parts of the world, these things are passed on, right? And doctors are able to benefit from that in identifying and diagnosing certain problems in families, right? But here, Charlie, you go to the hospital, whoever is on the musical chairs, you see them, all right? You may not even know the doctor's name. He or she may not even introduce themselves to you, let alone continuous care. Remind me, we'll take that on next week. And then we'll look at whether you partner with schools and other institutions to get this message across and run campaigns as well. Many thanks, specialist Ernest Enimopare. And many thanks to you, my discerning listeners. I have to dash and get you over to my man Lexis Bill. He cries, he obolo or muscular. He's been pumping plenty, but I suspect he was an obolo baby. And he calls himself Nana Diasa and all kinds of things. But he comes up next with the Joy FM Family Pop Quiz. Maybe one of these days, Abeku, we'll start feeding our own health questions into that Family Pop Quiz so that they stay away from these problems. They can stay. Don't go away. This is Joy 99.7 FM. My name is Nortey by nature. I'm done. I'm out. But don't go away. Lexis Bill is up next with the families on the Joy FM